agenda. So I will just go to the our speakers, and I will welcome Dr. Torsten Zubabeer, who is the main speaker today, our international speaker today. And to I mean, Dr. Zubabeer is very well known and does not need any introduction, but just as per the protocol, he is the head of the Department of Dermatology and Allergy, Chariot, and current position is the spokesperson of Comprehensive Allergy Center, Chariot, University of Berlin, Germany. And if we really see that he is presented a lot of clinical papers. In 2012, he has honorary doctorate of Athens University. He has been a managing director of Department of Dermatology and Allergy, Chariot, Berlin, head of Allergy Center, Chariot, and also the spokesperson of Comprehensive Allergy Center, Chariot. Besides this, he has membership and other, he's the president of Galen, president of German Academy of Allergy and Environmental Medicine, head of European Center of Allergy Foundation, honorary member of European Academy of Allergology and Clinical Immunology, honorary member of Austrian Society of Dermatology. There is a lot of membership: European Society of Dermatological Research, European Academy of Dermatology and Immunology, German Society of Dermatology. He's on the editorial board of JDDG, also Current Opinion in Allergy and Clinical Immunology, and advisory board of Allergo Journal. So welcome, Dr. Zubabeer. In fact, all Indian doctors are looking forward, though you are not new to Indian doctors, but still looking forward every time to hear from you, sir. So I will take this opportunity to introduce Dr. Kiran V. Godse, who is the moderator for this webinar series. He's a professor of dermatology and Department of Dermatology, D.Y. Patil Hospital and School of Medicine, Navi Mumbai. Dr. Godse has more than 105 publications, 6 books and 12 chapters to his credit. He is the immediate past president of the president of IIDWL, in fact, and he has been the national IIDWL vice president 2013, and also he coordinates for the Urticaria SIG. So Dr. Kiran Godse, welcome, sir, for this meeting, and he is our moderator for the webinar. We have amongst us a senior dermatologist and coordinator from Max Super Specialty Hospital, Dr. Mukesh Girdhar, who is from Delhi. He is a member of Urticaria Guideline Committee and one of the author of Consensus Statement of Urticaria. Dr. Mukesh Girdhar is recipient of Professor Sardari Lal Memorial Award, and also he has IIDWL Presidential Award in Dermacon in 2020. Also, he has award for Professor K.C. Kandari Award for Best Resident at AIIMS. He has been awarded Times Healthcare Award in category of Legend in Dermatology, IIDWL Presidential Appreciation Award at Dermacon Pune. He has been a Vice President of IIDWL 2018, President IIDWL State Branch 2015. He has contributed to a lot of books and on urticaria and dermophytosis, and he's published papers and contributed in the various national and international journals, and also delivered talks in number of national and global international lectures. Then we have very senior Dr. V.R. Janki from Chennai. She's a retired professor and head of Department Dermatology, Madras Medical College, Chennai. She has been recognized as a member of National Board for last 20 years, recipient of Dean's Commendation Certificate for Cause of Medical Education and Healthcare Delivery. She has been recipient of J.C. Shroff Award. She has been recipient of IIDWL Lifetime Achievement Award during Dermacon 2019. She is a convener and examiner of in the specialty of dermatology for PGs in most universities in South India. So among the various, she has given guest lectures at various centers in India and abroad, such as A.S. Thambai Oration, K. Rajendran Oration, T.V. Venkateshan Memorial Oration, and has more than 100 publications both in national and international journal, has more than 150 publications, presentation to her credit. She has contributed 2 chapters to IIDWL textbook of dermatology, a chapter in the recent advances in dermatology volume 2, and she's a co-author for Handbook of Dermomycology and Color Atlas. So welcome, Dr. Janki. And we have, he got an award recently for, what we say, rising star. So he's a rising star in India. And Dr. Abhishek Dey is from Kolkata, a dermatologist and cosmetologist, associate professor, National Medical College, Calcutta. His list of honors is Professor S.K. Pandya Award in Excellence in Dermatology. As I said, Rising Star Award in World Congress of Dermatology in Vancouver. Vishnu Priya Devi Award from IJDBL. Best Article Award 2013. National Skin Center Observer Fellowship 2013. American AAD Scholarship in Miami. International Society of Dermatology Mentorship Scholarship. National Award Dr. B.N. Banerjee Medal for the Best Original Research Paper. ILDS International Scholarship, South Korea. Again, Dr. Abhishek Dey has authored more than 13 chapters in different textbooks of dermatology. And he is the member of much international societies like ISD, EADV, ACSI, and IADBL, and is the first convener of the Academy of Association of Cutaneous Surgeons of India. So I welcome all of you, to this meeting on where the agenda is basically, before you, and the meeting on Urticaria, which will be moderated by Dr. Kiran Godse. And with this, before I hand over to Dr. Kiran Godse, I will. So there is a small video which I'd like to share. Sorry.
Opportunities abound, and the fastest economic growth achieved is also witnessing the fastest growth in the healthcare sector, which is why we've established our presence and positioned ourselves as the partner of choice to bring important healthcare brands across the region. Menarini Asia Pacific. As part of a leading global biopharmaceutical company, Menarini Asia Pacific's capabilities span the entire pharmaceutical development life cycle. A fully integrated biopharmaceutical company capable of research, development, manufacturing, regulatory affairs, and commercialization. Beyond end-to-end capabilities and cross-functional expertise, Menarini Asia Pacific has also become the preferred partner for leading healthcare companies around the world. Our expertise in building healthcare brands, flexible business model, and dedicated alliance management to create value for our partners have enabled us to make strategic acquisitions and licensing arrangements, consequently taking many brands to greater heights. Our rapidly growing businesses are bolstered by over 3,300 sales, marketing, and support professionals operating in 13 key markets. Our sales and marketing strategies, underpinned by local patient and physician insights, have helped many companies with varying needs tap into the Asia-Pacific growth story. Whether for new brands or line extensions, pharmaceutical or biotechnology companies can gain rapid market access to the region and manage their risks by leveraging on our strengths as a gateway to Asia Pacific. a reliable partner whose network and reach extends beyond the region, with a strong track record offering unparalleled customer experience. Founded in 1886, the name Menarini has through the generations become synonymous with the mark of quality. A trusted biopharmaceutical company with a strong tradition in partnering, an established presence in over 100 countries with more than 16,000 employees, Menarini is bringing its illustrious heritage and compelling values into the next century. And here in Asia Pacific, our ongoing commitment is to deliver quality healthcare brands, invigorating lives across the region. Your partner, your brand, at your service. Menarini, Asia Pacific.
So with this, I will request Dr. Kiran Godse to take over the proceedings of this meeting forward. Over to you, sir.
Yeah, Namaskar. Welcome to this webinar on Urticaria Decoded, what, why, which, and each. So we are going to learn from the experts, global experts about urticaria. You know, urticaria affects 1% of the population. So India being a huge country of 135 crores, there is a huge load of urticaria patients. And we have got only 10,000 dermatologists in India who practice. So as you can understand, there are a lot of patients we are going to see, and we do see every day. And urticaria evolved over last 10 years. We know the various causes, and the management guidelines are being changed every 4 years. And the architect of management guidelines is Dr. Torsten Zuberberg. In fact, he is going to tell us about the management of urticaria, latest developments, and guidelines in a nutshell. These were formed in December 2020 and are yet to be published, but we'll listen from Dr. Torsten about the management of urticaria, and then we'll have a panel discussion on urticaria management tools and tricks. We'll take the audience questions also, so please send in your questions in the chat box. And then there will be a presentation of unique case study of difficult to treat urticaria by Dr. Abhishek Day. So all in all, you will get complete solution for urticaria management, and I'm sure this is going to be helpful for us because we have a global expert, Dr. Zuberbai, with us. Over to you, Dr. Torsten, for the lecture. Thank you very much.
Thank you, Kiran. It's always a pleasure to work together with you, and of course, also a pleasure to work together with Menarini. We have done a lot of research projects in the past together, so I'm very glad to be here, although I'm not really there, but virtually I'm there. I will start my screen presentation, and you should now be able to see the screen.
Yes, yes.
Okay, thank you. Starting, of course, with the disclaimer that is being mentioned by Menarini, and I may also say that I personally, I have kind of bias in that way that I want to help our patients with really good drugs to have a better life in allergies. So that's my personal bias. But going on with my title, now I just have to see it doesn't move. Management of urticaria, the latest developments, and I look forward to the discussion round. I know, Kiran, you're going to moderate that, and it shall be a pleasure to again also learn from our Indian colleagues novel ideas or novel possibilities and discuss them together. And we've just been discussing life in Delhi. This is the city of Berlin with the Charité in the background and the German Parliament in the front. But just a glimpse, it's a small town compared to Indian cities. Urticaria, however, is a worldwide problem. And I want to mention with these pictures some things. Number one, it can look, well, strangely, if you look at the lower left picture, this could be insect stings if you did not know the history, swelling going away after a few hours. Angioedema, often present in urticaria, and we need to remember that the definition of urticaria is wheals, angioedema, or both. And there are cases with angioedema only, but they are histamine-induced urticaria. And this picture in the upper left is to explain there are patients with urticaria who have different subtypes. In this patient, we have spontaneous wheals and dermographism. So we need to be open-minded in looking at our patients and helping them. Now, another thing I always would like to mention and would like to be considered, and it's like other dermatological diseases, psoriasis, we know atopic dermatitis, there is a systemic component, and that's what I explain to my patients. It's an upregulated, active, hyperactive immune system of the skin fighting, but more is there, and there are comorbidities. So we do have comorbidities with allergic rhinitis, allergic asthma, other allergies, which are not necessarily, of course, the cause for urticaria, but they are present. And ideally, if we can treat two diseases, like with an antihistamine, like with bilastine, you can treat allergic rhinitis, you can treat itch in atopic dermatitis, and of course in urticaria. Well, that's great. But let's move on. I want to give you a very short glimpse at the history of the guidelines. We've been doing them in Berlin, and I've been doing them myself since the year 2000. And this is from the second status symposium in 2004, published in 2006. Non-sedating second generation antihistamines. From the year 2000 on, it was always a message: non-sedating second generation antihistamines should be used. And the message, if symptoms are not controlled, increase. Then a lot of things have happened. So 4 years later, it got a bit more refined, the guidelines. Again, 4 years later, a bit more refined, but it always stays the same message. In the beginning, use modern second generation antihistamines. And only then, as an add-on, if you look at the third line, it says add on to second line, or omalizumab or cyclosporine. And this has remained until now. This is the 2016 meeting, published in 2018. So again, only the order has changed. And in 2020, well, like everywhere, it was Corona time. We didn't have a big meeting like in 2016. We had an even bigger meeting, but virtual meeting. So very few people were present only. The majority, unfortunately, had to join in, like today, in a virtual meeting, which is not so nice. But I want to give you a glimpse of the new guidelines. They have not been published yet. They are in the progress of being published. Currently, we receive the comments of the reviewers, but the societies worldwide have already acknowledged these guidelines. And the current one from 2016 meeting is still there, but there are some differences. There's no difference in the methodology. We have a voting procedure, which is very important because we want to capture the ideas of worldwide voting. And we did that this time again, but with an online voting tool. And only if there was an agreement above 75%, it would be accepted in the guideline. And we use the so-called grade methodology, which is important. Grade means you check for the evidence, but you also check for the upsides and downsides, risks and benefits. This means a drug can be very good, but maybe adverse events, very often there's a stroke. You wouldn't recommend that drug. Or another drug can be very good, but it's extremely expensive. And then, of course, in the grading, you would say first you use a cheaper alternative. And strong recommendation is we recommend, and we suggest is a little bit weaker. Now, if you look at urticaria and look, many people think it's an allergy. it's not really the case. If it was an allergy to food, we would, with a very short effect of an elimination diet, see that there is an effect. There is the possibility that pseudoallergic reactions are present, and I would go into that a bit more in detail in the background, in the pathogenesis of urticaria. And I do that due to the fact that I've got feedback from many of my Indian friends, where you have a country with beautiful, well, tasty fruits and tasty food and many spices. And apparently these ingredients, spices, can lead to urticaria. So there have been several 13 together open label studies with subsequent single blind provocation using these diets. And I can only encourage my friends in India to try to do another real clinical trial with these diets in the Indian setting. And the number of patients responding is very much different, but it only helps in chronic spontaneous urticaria. I want to point out that it's aromatic components in food which do these, and in fact, it's not the residue, it's not the protein, it's not the histamine in there, it's volatile aromatic compounds, and that's why I highlight that for India. And these aromatic components of food, they are actually very small molecular weight. Now the question, of course, occurs: how could that be? Where is the connection? How does it work? And what we did see is that the permeability of gut, of the stomach mainly, changes before diet, and those responding, it's bad, getting better after diet. And this brings me to a very important aspect in the diagnostics of urticaria, further, that we should remember that there are changes in the gut, in the stomach. Gastritis can cause indirectly the passage of allergens and pseudoallergens more easily. And we have also published that in people who have gastritis and Helicobacter pylori as an infection, that in these cases, it only gets better, the urticaria, if also the gastritis is fully healed. So there is apparently also kind of inflammatory response, which has a neurological activation of mast cell mediator release. What I want to highlight here is, actually, we've got a lot of unmet needs in the diagnosis of urticaria. And the current guidelines have progressed in the understanding of treatment, but little progress was made in the diagnostics and in the pathogenesis. And I would really, really like to encourage people all over the world, also in our urticaria networks from Galen, to look at that in their own community, in their own patient groups, and really understanding the different subtypes, and then, of course, understand what is the role of different effects. We do have, of course, also autoimmune urticaria, which is playing a big role in urticaria. But again, why and how is that triggered? We need to find out. Now, with that very short excursion into food and comorbidities, what does the guideline say? The original guideline said, should routine diagnostic measures be performed in chronic inducible urticaria, for instance? No, because we do know a lot in the pathogenesis of chronic spontaneous urticaria. You should do something there, but not in the inducible urticaria. Regarding the time we have today, I focus in this talk on the management. And however, I just don't want to give you just the gist of use this or that drug, but I want to give you an idea how to explain it to your patient. And this graph is key. It was originally mentioned and developed by my friend Walter Canonica, who's an immunologist in Italy, and showing in asthma this minimal persistent inflammation, but it's the same in skin. In asthma, everybody knows it, that often mild irritation can cause asthma attacks again, because there is something under the surface. And for the skin, for the urticaria, it's absolutely the same issue. You have mast cells hyperactive in the skin, and you just need a little bit of a trigger. It could be an infection, it could be an inflammation, it could be mechanical irritation in some patients, and boom, it explodes again. This is relevant because you need to explain it to your patients. Many patients take their antihistamines on demand only. Not a good idea at all. This minimal persistent inflammation means we have to keep on treating. It's the same, by the way, in atopic dermatitis, in psoriasis. And you need to keep on treating even if the skin superficially looks good. And that's the second explanation. There is a very interesting thing about the histamine receptor. The histamine receptor is the one receptor in the body which is upregulated by the own ligand, histamine. And we do know that from allergic rhinitis sufferers, that in the end of the season in pollen allergic rhinitis, they have worse symptoms with less pollen flight, with less allergen challenge. And this is due to the fact that the histamine receptor gets more and more susceptible. Now, for the skin, it's absolutely the same. So I tell my patients, looking at minimal persistent inflammation and the histamine receptor, I tell these pathophysiological important issues to my patients. Say, hey, patient, I know many people want to take as little drugs as possible, but it's very important to know the drug like bilastine, it blocks the histamine receptor. It's simplified, of course, it's an inverse agonist, but for the patient, it blocks the histamine receptor. So the histamine cannot link to it. It's like a child protection in a socket. And remember, when the skin looks good from the surface, the next wheel is just about to explode beneath the surface. If you take these two things into account, please remember an antihistamine is like a child protection in a socket. It can only work if you put it there before the child plays with the socket. And this is relevant. So you need to have a consistent level of the antihistamine in the blood to be proactive for your disease. Now, of course, scientifically, it's a bit more complicated. And we do know that the mast cell has many triggers, many ways to explode, and it releases also much more than histamine only. And this is a graph depicted from my friend Marcus Maurer. As I already said, histamine is the key, but histamine also is the key in comorbidities, and we should remember that talking to the patient. Now, looking at the recommendations, should we aim treatment at complete symptom control? Yes, please. Well, the reason is, like I said, consistent, persistent, minimal inflammation, and it gives people hope, it gives them control over their lives. So please treat as good as possible. This is the old algorithm. So we have antihistamine, updosing, omalizumab, cephalosporin. Before, or maybe going back once, we also have the suggestion not to wait too long. If inadequate control after 2 to 4 weeks, step up. And we have this urticaria activity score of 0 to 3 from wheals and itch, adding to a number on the right side, like day 1, it's a 6. And then you sum up for 7 days, you have the UAS 7 score for a week. This, however, is even better to look at if you're a doctor, to take a month now, it's for 2 weeks depicted, and have this flow. And maybe then you have triggers like important work projects, stressful, or forgot medication. But if you give a treatment, you see the trend, like here, urticaria medication was given, and it goes down. the urticaria. So we have tools to look at the patient outcomes. Are second generation to be preferred? Yes, please. And first line treatment? Yes, please. And in 2020, same recommendation. We recommend as first line treatment for all types, relevant for all types of urticaria. And why not first generation? I do know in India, you have a high use, especially pediatricians, first generation antihistamines. You have a high use of generics, often not of the same quality as the original drug, which is much more vigorously controlled. But why not the first generation? Well, the real reason is side effects. Okay, well, maybe some people don't have them. The real reason is everybody. It's not a side effect, it's obligatory because they pass the blood-brain barrier, has a change of REM sleeping phases, and they are important for learning, they are important for concentration. And so if you then ask, well, now which one should I choose, second generation? There are several on the market. Now, actually, it's a kind of evolution. The first antihistamines developed were all first generation, all had these side effects. Why? Because they were so-called metabolites. They were to be metabolized. The newer ones, like here, desloratadine, they are metabolites already. And then they don't pass the blood-brain barrier as much as the first generation. But there's a difference between these, which are the newer ones, desloratadine, levocetirizine, rupatadine, and the youngest in this evolution, and the most novel is bilastine, which was found in 2010. And they differ. So bilastine is the newest development and has the highest receptor affinity, and also the lowest somnolence rates compared to cytosine or rupatadine. And this is key again. This slide, it shows the blood-brain barrier penetration. So antihistamines, like the old ones, hydroxyzine, Atarax, or ketotifen, often recommended, they rush through into the brain and have all the negative side effects. But if you look where is no penetration, it's up here. Bilastine is actively pumped out even. So there is really no way of getting into the brain, and this is an important achievement. And therefore, not surprisingly, somnolence rates are equal to placebo. And some people, and that's also interesting, who've got hay fever, who are tired due to the histamine, due to the hay fever symptoms, they say they are much more awake taking bilastine instead of taking other drugs. And it's also shown in real life, it doesn't impair driving. Well, I think not surprisingly, whereas hydroxyzine certainly does that, and especially in India, this can be really dangerous if you do that. So now if you look at the question, what is an ideal antihistamine, choosing the right antihistamine, we wouldn't want to have any interactions with liver enzymes, and we wouldn't have cardiac safety concerns, especially also if you may updose. So again, here, this has been shown for bilastine. It's perfectly safe in the liver environment, and ECG data from many studies pooled even 11 times updosing or multiple dose updosing have not shown anything. So actually the recommendation, the guidelines, which is of course not in the license, but it's the recommendation of the guidelines, updose an antihistamine up to 4-fold, it's certainly guaranteed to be safe depending on the study results with even higher updosing. And this is actually the question, is increase recommended? Yes, also in 2020, strong consensus. And why? Now, already I showed you the picture. It is useful at single dose to really block the histamine receptor, but there are other effects, and that's connected with the question, should we combine different antihistamines? And there's a consensus against doing that. Why? There is an old trial showing that combining different ones is not as good as updosing a single one. But the real reason behind that is that modern antihistamines have an additional effect on cytokine release by mast cells. And we have done this study at Charité with bilastine and checked in a cold provocation model here in cold urticaria that we induced wheals, and then we did a microdialysis of the skin, and we checked the response. So first of all, the response is dose-dependent, excellent. So nearly everybody had profited from bilastine. But what I want to show out in the skin, in vivo, mast cell cytokines were blocked in a dose-dependent fashion. And this explains that this updosing, which is not licensed, fully agreed, but useful and guideline suggested, recommended, is really working because they block pro-inflammatory antihistamines. And this is the reason why you should choose one. And actually, for me, that's also the reason why people with hay fever, for instance, say, hey, they are more awake, more active on bilastine than with other ones. Now, updosing in chronic spontaneous urticaria, there's also a trial, not only in cold urticaria, the fact is the same. We do have patients who need more than one tablet a day. Should they be taken regularly or as needed? I explained the background: minimal persistent inflammation, antihistamines work on the histamine receptor, and actually there is agreement to that. And the reason, again, minimal persistent inflammation. Now, of course, in the minutes left for me, what do we do if they are not sufficient in the treatment? Updosing is not good. So there is a kind of slide for the asthma GINA approach in a kind of reassess. And we've done the same looking at the old recommendation and the new ones. It's not the layout yet, but that's what you are going to see in the publication. We assess, we act, we adjust, we look always again at the treatment success, and then we go in a let's say amended fashion. For instance, cold urticaria need higher amounts in winter time than in summertime. Chronic spontaneous urticaria also fluctuates. So the aim is to control, but we check again and again, and potentially also updose. And that is also new, also recommended for omalizumab. We all know omalizumab is very expensive. It's an add-on therapy to antihistamines, but in some patients, the 300 milligram dose doesn't work. We have the data. Updosing works, especially in obese patients. Cyclosporin A, I definitely want to mention that. It's not cheap. It's cheaper than omalizumab, and it works. We have a problem with leukotriene antagonists. Leukotriene antagonists have been recommended in the past, but we don't have good trials. And actually, I myself have success with them only in those patients who have sinusitis. And then my personal interpretation is the sinusitis is an inflammation going on, and the inflammation triggers the urticaria. So if you treat the inflammation, if you treat the sinusitis, then you get a better response for the urticaria. Other alternative treatments, a lot has been suggested. I go through them quickly. The dapsone is interesting. Immunoglobulins, while there's strong evidence, but they are much too expensive and it doesn't really help. UV light treatment, well, there have been trials, but you can't do that all life long. And actually, of course, you already have a lot of sunlight in India. Now, looking at these trials, dapsone, there are very few studies. There are also from India showing there is an improvement. And in my own experience, there is an improvement, especially in those patients who have long-standing wheals, more than 12, 16 hours, not vasculitis, but nearly vasculitis. UV light, like I already said, it's been tested, but I don't think it's a clever idea to keep on using UV light. Intravenous immunoglobulins are too expensive. So we are left with methotrexate. Methotrexate is interesting. It's cheap. We dermatologists, we know how to use it. And there has been very, very few trials, one randomized controlled prospective trial. And I think this is something, I know it's been used in India also, a drug which we should look at more, but we urgently need trials for that. Azathioprine, a bit more expensive, immunosuppressive, not much data, you can't really judge on this existing study. But what we have is our unmet need in treatment. We do have possibilities to treat, we do have possibilities to aim at complete symptom control, but what we would like to know is much more about the causes and cure the disease, really cure it, find the cause, cure the cause, like immunotherapy in allergy. We should have something similar in urticaria. So to summarize and keep in time, we have to acknowledge urticaria is wheals and angioedema. There are people who have angioedema only, histamine-induced angioedema. This is urticaria. We have people who have wheals only. This is urticaria. We have people with wheals and angioedema. This is urticaria, and everything is histamine-driven. If you have angioedema alone, you have to rule out hereditary. You have to rule out the ACE inhibitor-induced angioedema, but the majority it's histamine. And antihistamines work as well in wheals as in angioedema. Antihistamines are the mainstay of treatment, simply because it's a massive explosion of the mast cells releasing histamine, so we need an antihistamine. And we only should use those truly non-sedating, which really do not pass the blood-brain barrier. The message is treat long enough and high enough. Don't be too cautious. I personally rather start with 4 tablets a day, 2 times in the morning, 2 times in the evening, and then level down. But that's my personal, it's not the license. And remember, histamine receptor upregulation, minimal persistent disease. And also for me personally, I think we should always also be careful especially if you updose, to really make sure that you have good drugs. And for bilastine, the original drug developed by Phase Pharma and then in collaboration with Menarini, being on the market in many European countries, worldwide, internationally used, and is really something where I'm happy it's now available also in India. With that, actually, I summarize with the saying we always have. Kira knows my last slide very well already. For a better life with allergies, it's Galen, the global allergy worldwide network, our motto from Charity and for the European Allergy Foundation. So thank you very much for listening, and Kiran, I give back to you.
Yes, thank you, Mostan. That was excellent. In fact, we got a lot of inputs on the new management and newer guidelines. Well, thank you for that. So friends, we are now have time for question answers and a panel discussion. The panel discussion, the title is Management Tools and Tricks. So we'll be focusing on the tools and tricks, what you use in your day-to-day practice to control the urticaria. We have with us Dr. V.R. Janki, a very senior actually consultant from Chennai. She has been associated with urticaria for many years. Dr. Janki and Dr. Mukesh Giridhar, again a senior consultant from Delhi. So we'll be sharing their inputs, and again Dr. Abhishek Dey from Kolkata. So all the panelists, you can join us here. Dr. Torsten, before we proceed, I just want to know what are the basic changes in the new guidelines as compared to old, like 2016 and to 2020. The 2 things which struck me was updosing of omalizumab and investigations. You advise about the more investigations. So can you guide us? What are your new guidelines tell us about the basic investigation in chronic urticaria. First, we know it was only CBC, ASR, and CRP, but now it is more.
Actually, we have in the basic laboratory testing, we have included the testing for TPO antibodies, so thyroid antibodies, because they can be relevant. On the other hand, it's an expensive test, and the question is how much change is seen in the treatment then. We do acknowledge that there is a kind of autoimmune background for urticaria. It's a kind of autoimmunity type 1 and 2 for IgE mediated reactions. There is IgE against Fc epsilon receptor, auto IgE, and others. But the question is, the therapy doesn't really change. It is good because then we know a cause and we can help the patient, because many patients simply want to know and they want to have investigations. In addition, I think the major change in the guideline is, like you said, omalizumab updosing, but also that we don't go unidirectional, but have this circle reassess. And I like that very much from asthma treatment, up and down and reassess. And we should also be talking to the patient again. Like I said, ideally, we want to find a cause. And very often in my patients, we have a mixture. We have a cause like a chronic inflammation, a chronic stomach problem, something where we can treat and at least make the urticaria much better, even if we cannot heal it out. And I think this is worthwhile reassessing the patient also.
Right. So new guidelines, we always know the basic investigation has been a CBC, ESR, and CRP. But the new guidelines also suggest that you can do IgE and anti-TPO. These tests are a little costly, but well, most of the Indians can afford it as it is done. So this will give us a rough estimate whether we are dealing with an autoimmune urticaria or an autoallergic urticaria. That is one thing. Yeah, Torsten.
Sorry, Kiran, I didn't want to interrupt. We also, of course, have discussed the autologous serum skin test. It's still there, it's possible, but it's time consuming and it's difficult. And normally as a doctor, if you're not in science, we don't have enough time and staff to centrifuge the blood and do this prick test, the skin test, cutaneous skin test. So that's the reason why these other tests are then more practical.
Right. So ASST is actually patient need to stop the antihistaminic, which is very difficult, and private practitioners in India find it difficult. So this via media is we can use IgE and anti-TPO to tell us whether we are dealing with a autoimmune urticaria. Generally, we'll have an anti-TPO test positive, and low IgE is also an indicator of autoimmune urticaria. So that will give you a rough estimate whether you are dealing with a truly autoimmune type or a autoallergic type of urticaria. This is a thing in fact, this is a new thing which we must do it in a day-to-day practice for the patients. Now we have got the tools and tricks. Dr. Torsten, what are the two things which you tell we must use as a dermatologist? I think that UAS and UCT, this is the two tools we can use in day-to-day practice.
Yeah, I fully agree. And for me, we didn't go into the UCT right now in this session, but UCT is Urticaria Control Test. It captures retrospectively how the last 4 weeks were. It's a good tool to see, give a first impression. For me, as a perspective tool, the UAS is perfect, especially for me, the UAS 7 is not so important, it's just for clinical trials, but this sheet of paper, like I showed, then sometimes you have patient, it really feels good. There's 2 days which there is a spike where they suddenly get worsening. And then I'm curious what was happening on these days. And it could be stress, it could be having eaten something, could be a drug being taken. And therefore, I like to use this UAS prospectively.
right? So the two tools you must use is UAS and UCT, which are easily available, which will give you assessment and which you can use in day-to-day practice. The tricks will come to know from our experts. Dr. Janki, in fact, Dr. Janki is one of the most senior dermatologists. Madam, what are your tricks to treat urticaria? Can you share us any of your tricks or what you use?
Do you mean me? Okay, Janaki, yeah.
Janki, yeah.
Such a difficult question. Usual trick, no? Nowadays, I never start on non-sedating antihistamine of the past. I straight away go for non-sedating antihistamines. And I am quite happy about it. Most of the time, I start with the two-fold rather. Very rarely, I go up to threefold. And I really take give a good gap of 6 to 8 weeks. Still, they don't respond. Only I go to the next level. As Zubarber has already pointed out, first 4 weeks we don't do much test. But as you rightly said, nowadays our weapon is IgE level and anti-TPO, which is available in India. That helps us to know it is autoallergic. And some of the literature mentions, even other simple tests like eosinophenia, basophenia, CRP, that is places where you can't do this anti-TPO titer. This basophenia may help, eosinophenia may help, even CRP, even though it is not specific to a certain extent, it may help. So my method of approach, trick is as much as possible, I convince them no steroids. As much as possible, I convince them, even though it may take time, you stick to the schedule. It requires a little bit psychological counseling also. You stick to it twofold. If it doesn't work threefold, it is definitely going to help. Then 2 weeks later, down the line, when they come, then only I just think of next level of treatment. At least 4 weeks I wait before I go to the next step.
Yeah, thank you, Dr. Janki. So clearly, you start with double dose, go to 3 or up to 4 dose also.
Correct.
That's a trick. And no steroid is important. Please don't start steroid straight away for chronic urticaria patients. And Dr. Mukesh, what are your tricks in treating patients of urticaria? What is the one trick which you must tell to our fellow colleagues, which they can use it in day-to-day practice? Unmute me yourself, Dr. Mukesh, unmute.
So before that, I wanted to make an observation. So we are 3-generation dermatologists sitting here in this panel discussion. Dr. Janki, 1 year my senior, 1 generation my senior, and Abhishek, almost 1 generation my junior. So that's beautiful that we all follow the guidelines, the way they have been drafted and the way they have been very scientifically and reasonably drafted. So I feel very happy, sharing the, the meeting with Dr. Janki here. Now, so far as tricks are concerned, see, there are different molecules. Sometimes different molecules are for different purposes. Like, for example, if you have an SCID-induced urticaria, you will try anti-leukotriene agent. Like you have a food-induced urticaria or asthma-associated urticaria, you will be going for Montelukast kind of thing. The other thing is there is a trend of dividing the dosages of antihistamines. So when we are dealing with a drug like bilastine, which has a duration of action of well over 24 hours, so if I have to give 2 tablets a day, I'll just give one dose daily. So this is the other small thing which I do in my practice, and I am very fearless in giving in the morning before breakfast because there is no sedation. So that's another thing. So it's evolving field. We keep learning every day. And as Dr. Janki was mentioning, for the poor man, basopenia, maybe a very basic, indicator for me that the patient may be having autoimmune urticaria. So there can be so many other things if when they are talked in a particular context, I can talk about it.
Yeah, thank you, Mukesh. So obviously you have to find fearless to start the antihistaminic straight away. You can start with 2 tablets. That's a good message. And Dr. Abhishek, what are your tricks in treating urticaria? Something which you can tell to our colleagues.
As Mukesh said, I was already suggesting, and other people also suggested that I try to stick to the guidelines as much as possible, and most of the patients I get good results. That's what something I need to tell the delegates. So if there are 99.9% chance if you stick to the guidelines, then you get best results out of our patients. Now there are a couple of things I need to say. Urticaria looks really angry, really bad on the patients. It have a havoc on their mind and psyche. So it's the first counseling. I need to spend some time with the patient, make him understand the disease prognosis and the disease process, and make them understand also the is very treatable disease, if not curable disease. So that's something a counseling always helps. And then I emphasize on complete symptom control. There is a habit in India now. They allow the they take it the medicine. Even the GPs encourage that also. When the symptoms comes, you take one antihistamines. So I make the very first counseling. I had to make them aware that whatever they have done, they have to change it. They have to take it like a thyroxine, or a thyroid medicines, or blood diabetes medicine. It's whatever you have to take it as per schedule. So that's something I also tell. And also I make them understand only when we have complete symptom control, and only when I can gradually decrease the doses, then we have the best possibility of having a long-term remission in these patients. And last one thing, which is not often practiced in India, and I always encourage my junior colleagues to do that maintaining a UAS 7 score is not that difficult. Most of my patients can actually maintain UAS 7 score. This is really helpful when the patient can see how their UAS 7 score get dropping every month, and they feel confident in your treatment. So this is something you can do for a better compliance from the patients.
Yeah, right. So, well, all of you have told the tricks. So I must tell my tricks. I say
Yes.
that to all the doctors, that you must give 7 tablets before you say that patient is not responding to antihistaminics. And what are they? They are the 4 tablets of antihistamines, your choice, 2 tablets of ranitidine, and 1 tablet of Montelukast in dose of allergic rhinitis. So these 7 tablets you give, and still patient says, doctor, I got hives, then it's a time that you must go to second step. Although ranitidine and Montelukast are not mentioned in the guidelines, but many times we do recommend to our Indian patients, because second line is little difficult, like cyclosporine and omalizumab. Most of the time patients may not afford it, but well, this 7 tablet works in many of the patients, almost 70 to 80% of patients. It will work. That is our thing. Well, we have got a few questions about the vaccination and COVID vaccination and urticaria. Dr. Torsten, there are some reports which claim that those patients who have got extensive urticaria or extensive allergic or atopic dermatitis, these patients can have trouble with COVID vaccination or anaphylaxis reaction. There are some reports. So what is your take? Those who have got extensive urticaria or uncontrolled urticaria, what is your advice?
Well, actually, Kiran, you know as well as I do, we are both members in the Galen Urticaria network UCARE, and that we have gathered data from all around the world. So first message, people with urticaria are not subject to any higher risk of anaphylactic reactions. Second message is also they should be vaccinated, but people with urticaria can have an increase of urticaria symptoms shortly after vaccination. This is not an allergy. It's simply like in all urticaria patients, when you have a common flu, if you have just even a bacterial infection of a tooth, there is a flare-up of the urticaria as soon as the immune system is actually fired. And it really is due to the stimulation of the immune system, urticaria symptoms worsen. So our advice is simply increase your antihistamine dosage during that time, and know that this is not a reason that you should not take the second vaccination, because in most of these vaccines you need 2 injections. Yeah, but I think that's truly relevant to make people feel safe.
Right. So basically, urticaria is not a contraindication for COVID vaccination, Only thing is, obviously, uncontrolled urticaria, please control the urticaria and then they can go for the vaccination. For uncontrolled extensive atopic dermatitis, obviously you must control the disease and then go for vaccination. That is the thing. Well, because obviously every day we get questions that can I take vaccine? So please, you all of them must take vaccine. That is one thing. So because the vaccination is one thing which is important for all of us, and India is quite way ahead. And in fact, India is vaccinating every day. One New Zealand, that one small country, they're vaccinating. So that's the speed with which we are vaccinating, and hopefully we will come more of this. Well, there are many questions coming out. This one question, Dr. Torsten, he has tried to ask you clearly, Doctor, how do you grade bilastine and fexofenadine? Which is the one which is the one which you prefer?
Actually, quite a very interesting question. Also, the other question I've seen, can we go above fourfold in obese patients? And both are very interesting questions. Well, first of all, fexofenadine is a non-sedating antihistamine as well as bilastine, and it's I would say the second best regarding the penetration through the blood-brain barrier. And bilastine is slightly better. It's slightly stronger than fexofenadine, but both are valuable antihistamines in our portfolio. Now, interestingly, I showed this effect on the cytokines, and they have slightly different effects on cytokines, bilastine and fexofenadine. So you may come across an individual patient who's profiting more, but you could not say a prediction just from looking at the patient. So to be quite frank, both are modern second generation antihistamines, but bilastine is slightly stronger. Bilastine is currently in head-to-head trials the strongest antihistamine in the market. But the other question is, can we go above fourfold and increase obese patients? Very interesting question. It's never been investigated. We do know that bilastine has a plasma protein binding of 90%. So the most likely the answer would be it wouldn't help in an obese patient to go above fourfold, but we simply do not know. To be quite frank, in omalizumab, we do know that obese patients often need more than 300 milligrams per 4 weeks.
Right. So, well, fourfold is the dose. Don't go beyond that till the studies convince us that more than fourfold works. But otherwise, fourfold is the answer. We have Dr. Torsten in India, bilastine, which was a generic, which was available since a year, and now we have got the original bilastine available from Menarini. Dr. Mukesh, you must have tried both the original bilastine and the generic one. What are your observations? Dr. Unmute yourself.
Yeah. So sorry for that. So difficult to make any definite observation on this, but I would say when I have used this Menarini bilastine, it hasn't failed me. So at the, you have not shifted any patient from one brand to the other brand. So it will be very, very difficult to make a very strong passing remark on this. But as I always believe that the originator brands are always, they are more sure of themselves. They are more concerned about their efficacy and purity and everything. So I will always prefer to use the originator brand rather than a generic brand.
Yeah, that's right. In fact, if you can afford Mercedes, don't go for any other car. So the best brand is available with us in India. That is from bilastine, from Menarini. So you can always use this brand and see the difference. Dr. Abhishek, you did a study on real-time study on the bilastine, which you got published also. So can you give us the salient features of that study?
Yes, sir. It is about 50 patients we have included in bilastine. These people are already being treated with at least a standard dose or double dose of antihistaminic, other antihistaminic, including levocetirizine, fexofenadine, and you shifted to double dose of bilastine straight away. And some of the patient we need to elevate the doses. So out of the 50 at least 36 patients got excellent, 46 patients got excellent response with bilastine, either 2-fold or 3-fold or 4-fold doses over 6 months. So we actually noted the US7 score, we noted the quality of life. So everything was quite improved and quite, I would say, quite impressive. 4%, however, required omalizumab or cyclosporine. That is always possible in urticaria.
Right. So bilastine has shown efficacy in Indian patients. And obviously, we know that bilastine, in fact, Torsten, I just heard that bilastine got the perfect 10 score in the area guidelines. What is this perfect 10, or what does it indicate?
Actually, I don't know the perfect 10. We have the ideal antihistamine, if you mean that.
Yeah.
Okay, yes. Actually, that's from the ARIA originating from Jean Bousquet, that it should be having no side effects, no interactions with cytochrome P450, rapid action, and no sedation, and all that is covered by bilastine. I wanted to make one remark, Kieran, if I may, regarding the discussion of the generics. I don't know if everybody in the audience knows the definition, the legal definition. A generic has to show not efficacy in a clinical trial, only the pharmacodynamics and pharmacokinetics are checked. That means the uptake, the bioavailability is checked, and the generic has to be at least 80% or up to 125% bioavailability. Now, you may say this is not relevant, but if you tell your government, I think I should only pay 80% taxes next year, they would say, hey, this is relevant. Now you wonder why governments make this so easy for generics to be produced. And you could say, well, in single dose, well, 80%, 100%, there is a difference. But if you now updose and you use a generic, and suddenly you only have 4 times 80, 320 instead of 400 milligrams activity, let's say like that, or percent activity, there is a big difference. So this is one thing which I think is simply not fair by governments worldwide to have generics uncontrolled. They should also have clinical trials to prove efficacy. And like Mukesh correctly said, there are different brands and you never know which is well controlled or not. And with the original, you simply know you don't have any copy.
Yeah, right. So important is to use the best brand available to give the best result to the patients, because patient is important. He must give a complete relief. And the difference between the originator and the generic is not much. So obviously the originator is always preferred. Dr. Janki, you have been practicing more than 30, 40 years. You've got the longest experience with all of us. So I just want to know, when an urticaria patient comes to you, a chronic urticaria patient, what is your approach? What you tell that patient? Apart from investigation, you already told us, but what else you tell the patient?
I mean, regarding how to approach.
Yes.
I mean, as Abhishek said, counseling is very important. We tell them to be patient, but at the same time, there are so many factors. Young college students come, geriatric patient come, office goers come. So depending upon the individual, we have to, we have to change our strategy. Sometimes, young college students who desperately want something, we definitely go to the next level. Whereas geriatric patients, where they can prefer to wait for some time, we convince them 2 doses more than enough. If at all, you take a 3rd dose in the afternoon and try to manage. And most of the time, talking is more important. And investigations, as you rightly said, even if we sometimes feel they don't need, the patient desperately needs. At which point of time, for their sake, I do some investigations. And regarding going to the next step, as Dr. Zubarbier mentioned, I have not used omalizumab at all. I am quite happy with cyclosporine for acute tiding over. As the patient is on cyclosporine, I simultaneously start them on methotrexate. I have some 20-30 patients who are doing very well with methotrexate, very well. One income tax commissioner, he suffered nearly for 2 years. I thought, and finally, with great hesitancy, I put him on methotrexate 10 milligram. Remarkably, he did very well, and his urticaria never came back. That is, individual variations are there. So my choice, as much as possible, try to manage only with non-sedating antihistamine, convince them. Sometimes we say no steroids, but as you rightly said, my 40 years of experience, some sudden crisis, examination, marriage, some critical situations, when we desperately want to do something, we do give a short course of steroid and withdraw. Even though academically we say no steroids, and most of the time I also never use, but I do use steroids when we definitely need it, a short spell and withdraw. So first option, only non-sedating, counseling. Second option, cyclosporine and methotrexate. Dapsone, of course, I have never tried. Colchicine, I have tried in a couple of patients when there is a suspect some associated infection or associated autoimmune, which has definitely helped. Sir put very good slide regarding Dapsone. He said excellent response. Somehow psychologically we are a little bit afraid of Dapsone. That is why it is preventing us from using. Otherwise, it's a good drug. So instead of Dapsone, I prefer colchicine. See, this is why I approach. With all these things, some of the chronic urticaria, nearly 10% of the patients do come and ask, why don't you do something?
Thank you, madam, for your wise words of wisdom and the thing. Obviously, the Dapsone, colchicine could be used for vasculitis. Dr. Abhishek, you would like to add something?
Yeah. Sir, I just want to have a questions to you people. Now that we know that there's two distinct groups among chronic spontaneous urticaria, one, people who are more autoallergic, type 1A, type 1, and another is type 2B, autoimmune. So if we can do those, tests to know which one is type 2B, and should we start directly cyclosporine on those patients who are type 2B? I mean, we suspect that to be type 2B, or we should give omalizumab, wait for it, it's not working, updose it, and then go for cyclosporine.
Abhishek, can I answer that question? Actually, type 1, when you do the IgE level and anti-thyroid, that is TPO level, there omalizumab works much better. Where you have associated other atopic diathesis. Whereas, as you rightly mentioned, type 2B, where it is mostly associated with other autoimmune diseases, in those cases, cyclosporine, methotrexate, in other words, immunosuppressive will be a good option. So, omalizumab only for type 1, whereas type 2B, we prefer immunosuppressive. I mean, recently,
yes,
in 2021, nice article has come with a big tabular column.
Yes, ma'am.
Yeah, Dr. Torsten, what is your take? Should we straight away go ahead with cyclosporine for this? Because guidelines say that you use omalizumab in all the patients, irrespective whether they are autoimmune or autoimmune.
Kiran, thank you for the question. I do, of course, see the idea behind what Dr. Abhishek just explained. The guideline is pretty clear. Go for omalizumab first, and the reason is, among others, also omalizumab is licensed for urticaria. It's a legal reason, whereas cyclosporine A is not. In many areas of the world, like in my country, in Germany, in case a patient got an adverse event on cyclosporine A, which could be even a serious adverse events with kidney or liver problems, we would be liable as a doctor if we did not use omalizumab first before we did that. And I think there are some problems somewhere in the background.
Janki has a problem. Janki, you are still visible. Don't worry. You continue.
That is my reason why in the guidelines we simply say yes, we start with omalizumab. But I think it's valuable to have these scientific discussions, because we do have patients who do not. We have patients who beautifully, quickly respond on omalizumab, and others slow responders. But for me, apparently, although the theoretic discussions are there, in real life, nearly everybody responds to omalizumab, independent of the background of the autoimmune disease. So I think I would stick to the guideline here until we would have really more evidence, although I like this line of thinking. Actually, this is interesting. We also have this question in the chat. What other tests do you do? And for autoimmune spontaneous urticaria, and this is a bit disappointing. Of course, we know from background research, we have these autoimmune type 1 and 2 and 2A and B and other real pathophysiological distinctions. We have checked for IgE against different cytokines also. But the problem is none of these more refined tests are available in clinical routine. The same holds true. There is a nice test with sugar solutions to test for changes in the gastric mucosa permeability. It's a very interesting, it's a predictor for that the diet would work, but it's not commercially available. So in fact, the answer to that question, what do we do? It's disappointing. We do very little. We do try and error in treatment. We can do the autologous serum skin test. I do not do it on a routine because we simply don't have the capacity, and it doesn't explain really what really the pathophysiological background is, and it's not correlated to treatment success. We've done that in the past long series. So we have several patients also who are autologous serum skin test positive, although the urticaria has ceased and has actually stopped being there, but this test is positive. So for me, the predictive value is very low. So unfortunately, this question is disappointing.
Well, the questions will come, and this thing. Yeah, there is one more question from the role of mast cell stabilizers in urticaria. Dr. Roshan, do you still use the ketotifen?
I can tell you it's very easy. The mast cell stabilizer chromoglycate is not resorbed from the gut. So it's a valuable drug in mastocytosis with gastrointestinal involvement. It's not, most likely, not valuable in urticaria because it's not resorbed. However, what we have not looked at is the gut. And we have new trials in allergic rhinitis with the microbiome of the gut, and could show that with changes in the microbiome, activity of allergic rhinitis and double-blind placebo-controlled testing is associated. And this is something which we have not looked yet at profoundly in urticaria. So it's always good to be open-minded, but currently I've never seen that chromoglycate would help in urticaria.
Right. There are a few more questions. Dr. Mukesh, how often you review your chronic urticaria patients? You know, how often you call them, and how often you titrate the dose?
Okay, so when the patient of chronic urticaria comes to me, first of all, I have to tell the patient that I'm going to put you on a class of medicines which are second generation antihistamines, which are safe to use. And I tell them that even if you have to use them for 10 years, 20 years, they are not going to cause any harm to you. So don't be hesitant to take them. Now take as much as you need actually. So I will start them on one dose only if it's a naive patient, but most of my patients have already taken treatment for urticaria somewhere. So my starting dose is double the dose or 4 times the dose. So once I start the patient on antihistamine, normally I will like to call the patient after 2 weeks to see how the patient has responded. If the patient has come from far off place, I will tell the patient that if you are controlled on this much of dose, come back after 3 months. There is no need to come before that. Now, once the patient comes on the second visit, see, counseling of the patient is an ongoing process actually. You have to prepare him for the long haul. Patient is, the next question automatically comes is, okay, well, I'm controlled for how long to take the medicine? So then I tell the patient that, well, we give them some statistics also, that this many patients resolve in 6 months, 1 year, this many resolve in 3 to 5 years. And so many people keep having it beyond 5 years also. We don't know what is going to happen in your case, but in any case, you are on a harmless medication. So keep taking it. Maybe you come after 3 months. So normally I will call the patients every 3 months. And once I see that the urticaria is absolutely controlled, absolutely zero UAS, then I will, think of reducing the dose. And then reduction of the dose is also by 1 tablet at a time, not faster reduction. So every month or 2 months, they can reduce 1 tablet and see what happens.
Yeah, right. So gradual reduction is the key. So that is what the new guidelines, when will come, you will see that circle with reassess this thing. Dr. Torsten, can you just tell us about that circle and how that is from what we'll be getting in the new guidelines? They are very catchy to understand. So just give us the glimpses of that circle which you just posted. You just showed us on our PowerPoint.
The circle, you mean act, assess, readjust.
Act, assess, and reassess.
I think the most important message here is to stimulate colleagues to listen more carefully to our patients and not just send them away on medication and then maybe see them again in 6 months. And also remember that the same procedure could be used for different subtypes. We have patients who have 2 diseases. They have chronic spontaneous urticaria, they have cold urticaria. So in winter, they would need a different medication compared to summer. And this is actually incorporated in this circle, that it's always important to think again and talk to the patient. I feel personally that I often have discovered very interesting triggering factors, but just meeting again the patient and then listening to the patient, looking at this, what we discussed, the UAS score for a month, say, hey, what happened there? Well, there was a funny incident I once checked with the Russian colleagues. It was always visiting the mother-in-law when urticaria got worse. And this could be stress, because mother-in-laws can be stressful. But in that case, it was that this mother-in-law used aspirin to preserve the canned food, because aspirin is a very nice antioxidant. It's cheap. And I also know, then I learned that in South America, it's custom to spray salad bars with aspirin solution. So this was very interesting, and you could not have found that out with the UAS, without the UAS score. And I can imagine, I don't know if it's used in India, but I can imagine that it's cheap as an antioxidant at some restaurants, that we say, hey, it's easy, spray it over the salad bar and everything looks green and nice.
Right, interesting story. Well, next time we'll be aware. We need to find out from the our kitchen this thing, from the whether they're using this thing. But obviously there are, in fact, many preservatives, dyes, chemicals are being used to give the color to the thing. So many times we tell the patient not to use red, orange, green colored food which you get from outside, from the street food. Chinese bale and all is very, very popular in India. So we always tell the patient to avoid this outside artificially colored food, which could be triggerant due to the colorants in it. So that is important. Obviously, it's a good story and we must understand. So truly, you have to be really find out the true detective to find out the cause of urticaria. Dr. Abhishek, well, we have got patients of urticaria. If they do not respond to 4-step, obviously the omalizumab is the choice, and the cyclosporine. But what are your other favorite apart from omalizumab and cyclosporine?
Most of my patients I give omalizumab, and given that omalizumab now is available in India in the biosimilar form, the cost has almost gone 1/3 of the original molecule. So it's become increasingly easy for us to omalizumab use these days. And cyclosporine is other drug which I use. I have tried autologous serum therapy in many of my patients, especially when I am in or practicing my medical college. So there I have infrastructure. So we try autologous serum therapy. I have given hydroxygen in some patients who are cannot afford omalizumab or cyclosporine. So in India, sometimes it can be difficult. There are other patients, like as you said, sir, I have tried H2 blockers also and methotrexate also. And methotrexate, I find it's not a very good drug for urticaria, but some of the patients respond well, and especially in children. I mean, some of the children where cyclosporine I have already given for 3 to 4 months, and I do not have too many drugs to shift the patient to, then methotrexate can be a good choice of drug.
Yeah, right.
May I comment, Kiran? I think
Yeah,
this was very nice what Abhishek just told us. We should also be brave and try ways, but then we should also try to publish if successful. And also what you pointed out, we have to acknowledge not only in urticaria and all over in medicine and dermatology, individual response. This is a real problem of clinical trials. We always look at the average response. We don't look at responders and then reinvestigate the drugs. And I think we would have a much better understanding of medicine if we looked at individual responders. So I think can only say, please be active, try out, but publish. And that's where UCare is also good for, the Galen network.
Right. You rely on evidence and then the experience, both come handy to treat the thing. Yeah, we have almost 40 minutes of discussion. So we are just last few minutes of the discussion. Dr. Janki, the last question for you. You have seen urticaria treatment evolving from the older antihistaminics to newer antihistaminics. So what do you see the quality of life and the control of urticaria in last 40 years?
Definitely there is a remarkable changeover. 96 or 2000, I should say, when we shifted from first generation to second generation, because those days, pheniramin maleate and all the older antihistamine, the patients complained drowsiness. Senior individuals, we are very much afraid of retention of urine, glaucoma, and all the other side effects. So there is definitely a dramatic change of events, and I mean, I can just say 70s, 80s, 90s, 2000, 2000 onwards, management of urticaria with the second generation antihistamine is a big forward step, and abdosing the antihistamine is another big step. As I told you in the very beginning, I am very comfortable with second generation. Very rarely I use sedating antihistamines, that too not urticaria. Urticaria associated with other disorders, probably I may prefer at night. But for that, I am very comfortable with non-sedating antihistamine. I am very comfortable with doubling the dose or tripling. Of course, I have never gone fourfold at all. Most of the time, I manage a triple. And as Mukesh rightly said, 3 months down the line, you make it into 2. 3 months down the line, we make it into 1 gradually. And the most important of all these things, we have to tell the patient, none of the second generation antihistamines are steroids, because with all our counseling, they will ask, Madam, is it safe to take this much of Bilastine daily for so many months? And we have to tell them nothing will happen. And repeatedly we have to tell it is not a harmful drug. Definitely there is a big change of practice from 70s to 2000 to 2020. And another big plus point, we have so many available options. Even for doubling the dose, tripling the dose, we have so many available options. So that is an added advantage.
Thank you, Dr. Janki. We are at last 2 minutes. I understand we have got other commitments. Dr. Zubar, last question about the food allergy. We just got it from the chat. The patient, they use food allergy panel in urticaria, and then the doctor is asking whether can we decide about the food allergen panel and the elimination diet? So your take on this.
Thank you, Kiran. And actually, it's very simple. Number one, if you have a patient history of real food allergy, that means eating something, having symptoms like vomiting immediately afterwards, this is important to look into, and skin prick testing, for instance, is valuable. But very often, this is a comorbidity. It's not the cause for urticaria. Whereas what I said, pseudoallergies, and like you said, also for the street food in India, where there are often preservatives and antioxidants used, is often a cause for chronic spontaneous urticaria. But this doesn't have any testing. You have to use an elimination diet, but you have to use it for 14 days. And I think this is the most relevant message here. But the second message, which is relevant, there are comorbidities very often to urticaria: allergic rhinitis, atopic dermatitis, itchiness of the skin. And it's good if we can use like a drug with bilastine, which has also effects on these diseases, to explain it to the patient that you have synergistic effects, which makes it even more important for the patient to take it. And like Mukesh pointed out, the most important is talk to the patient, give trust to the patient. People are afraid of drugs. You don't have to be afraid. There's not a single case worldwide of a long-term side effect with a drug like bilastine. And this is comforting. We should tell that to our patients. And then there was another question. My experience with omalizumab compared to the biosimilar, there is no biosimilar on the market to omalizumab for me available. So I can't say anything about that.
Yeah, right. Well, thank you very much for this interesting discussion. Biosimilar is also available in India, and obviously the original is original. Biosimilar we need to test and really do head-to-head studies. Yeah, Dr. Mukesh, last words from you, then we'll be closing this session.
Okay. First of all, I have been enriched a lot today, listening to Dr. Zubarwiyar, ma'am, Janki ma'am, clinical experience, our exuberant Abhishek. We all keep learning in the management of urticaria. We keep getting wiser with with the subsequent interactions all the time. And for that, I must thank the charity team as a whole also, because you have always been with us in taking urticaria forward so far as the management part of urticaria is concerned. So that is all I will want to say, sir. I want to leave now.
Thank you very much for interesting this thing. Bye from all of you. But please stay tuned. We have got interesting cases by Dr. Abhishek Day. He'll be sharing some interesting cases, and from that we have got some learning points. So Dr. Abhishek, please go ahead with your presentation. And bye for here, Dr. Torsten. Bye.
Bye everybody.
Bye. Thank you. It was quite an awesome experience. A lot of learning point, a lot of new take-home messages. Let's see, and we'll now discuss about certain cases which comes to our day-to-day clinic. All of them are real cases, and see how we should be with all those knowledges given by our wonderful panelists and the faculty. How we can approach those patients. So here comes the fast patients, which is an itch which just doesn't go. Now this is a 52 years old male patient presents with itchy evanescence rashes for 9 months. Now there are history of few episodes of swelling of lips and face with no difficulty in breathing. There's no history of aggravating or relieving factors. No history of known allergy to food or drugs. So of course we find this rashes quite common in our practice. Now what happens to this patient when you do take the history? There's no history of inducibility. That's some part we need to know. There's already few visits this patient has to pay to the emergency department in the past few months. The patient also suffers from a known case of hypertension since the past 7 years on irregular treatment. And when you do test our blood pressure in the clinic, then we couldn't find out that the patient's blood pressure is not good, not well controlled. So every single visit we are finding that sometimes the patient blood pressure is high, sometimes the blood pressure is low. So the patient usually forgets to take the antihypertensive medicines, and it's not a good thing to do. Patient already has taken treatment for urticaria. Patient has taken hydroxygen, levocetirizine, methylprednisolone a couple of times, montelukast. Patient has been given injection hydroxyzine at least 3 times during this course of the disease. We did test for dermographism, which is present. We did a test for pressure, ice cube, and vibration, where we found no reactivity. As we mentioned that urticaria activity 7 score and urticaria control test had to be done, and we found that the patient had quite high UH7 score and UCT. So the disease is quite uncontrolled in spite of the patient taking on and off antihistamine. So provisional diagnosis is pretty easy. So it was a case of chronic spontaneous urticaria. From now, the discussion, you already know that. But the issue is, what are the laboratory investigation I usually send to those patients? When the patient is a chronic spontaneous urticaria, I go for a complete blood count, which includes 5-part analyzing. We need to take this absolute basophil count and absolute eosinophil counts into our practice. Then I also go for a CRP test, which are both are in this particular patient, which is normal. I did go for a TSH just to find out there's an associated thyroid disease or not. Yes, there's some elevation of TSH, which is 5.5. Anti-TB antibodies were within normal limit, and IgE was pretty high in this patient. So these are the lab pictures for that patient, and this is the routine panel I usually go for my patients of chronic spontaneous urticaria. I also did a autologous serum skin test, which came out to be positive. So how do you manage this test? These cases. So we have already know that when the patient comes with urticaria, we have to updose our antihistamine. And in this patient also, I have given a 4-fold elevation of second generation antihistamines. There are some response, but as you can see, the response is not good enough. The US-7 score was still holding for 14 to 22 in the last 1.5 months we have treated the patients. So what could be next line? And next line of treatment, as we already know, that should be omalizumab. We offered the patient for omalizumab. The patient couldn't afford that because it was expensive. That only omalizumab available at that point of time was the international brand, and which is quite expensive for many of our patients. And the patient didn't have any advantage of having some insurance. So we tried for 9 injections of subcutaneous autologous serum therapy at weekly interval, and the condition actually didn't help in AST, and this actually condition worsened after the treatment. So what could be our next line of treatment? So you may think about cyclosporine, but as you say, that patient has come to us repeatedly, and we found the patient blood pressure is irregular. Patient doesn't take antihypertensive seriously, so it was not a very good patient for cyclosporine. If you see the guidelines, this was the guidelines. As a second line of treatment, we should be giving 4-fold elevation of second generation antihistamine. We can give omalizumab after that. If doesn't respond, then cyclosporine. So many of these options are not there for us because omalizumab the patient couldn't afford. Then if you see, there are other guidelines which also almost on the similar line. We tried fast generation antihistamine. This patient didn't give much of response. So we have this Indian guidelines where we have certain other drugs, like we already mentioned about autologous serum skin therapy, which didn't work on the patient. Methotrexate could have also been tried. However, one thing happened while the patient was on the autologous serum therapy. The omalizumab was there as a biosimilar form, which is quite inexpensive in compared to the original patent bag. The patient was given again options of omalizumab, and in this kind of patients were on a high Ig, otherwise refractory, omalizumab is possibly still remains the drug of choice. Now moving to the second case. This is a boy who loves to go to the gym, but always have some problem arising when he do heavy exercises. It's a 22-year-old male who complains of itchy wheels, as you can see from the photograph, after physical exertion, walking in the sun, eating spicy food, and when he is angry. A photograph taken by the patient showed that monomorphic pinpoint wheels. Patient also is a known case of bronchial asthma. So what is your diagnosis? And diagnosis is pretty straightforward. We know the patient is cholinergic urticaria, and many patients of cholinergic urticaria, of course, we can diagnose this very easily by the clinical monomorphic pattern and also the history the patient gives with the aggravation with heavy exercises or sweating. That is quite obvious. But we also need to know that many of the patients of cholinergic urticaria also have associated atopic diseases. So what are the investigations should be done? We can do certain provocation tests either by using exercise like treadmill test or stationary bicycle test, or also can ask the patient to take a hot bath at 42 degrees centigrade for 15 minutes. There can be other tests done like intradermal injection of acetylcholine or methacholine, which can produce the satellite wheals, as you can see from the photographs. Now, how to treat cholinergic urticaria? Now, here we need to say that as far as the standard guidelines, all urticaria guidelines parts say that whether it's a chronic spontaneous urticaria or chronic inducible urticaria, the guidelines algorithm doesn't change. We still need to use our antihistamines fourfold, and after that, if it doesn't respond, we can go to omalizumab or cyclosporine. There is a guideline which published for cholinergic urticaria. It's not very different from the standard urticaria management. However, they divided into cholinergic urticaria with normal sweat function and hypohidrotic cholinergic urticaria. As you can see from here, in hypohidrotic cholinergic urticaria, there are more chance we need a steroid pulse therapy on those patients. In case of cholinergic urticaria, normal sweat function, usually the standard line of treatment should be good enough. There can be certain alternative treatment, like we can add H2 blockers, we can give propranolol, which sometimes works. We can give montelukast. There have been suggestion of giving botulinum toxins. There has been given high doses of danazol. So all those things can be given. Very commonly done things in India is topical application of keratolytic agents. It's supposed to be effective, especially the patients in hypohidrotic cholinergic urticaria. Now, another case, here the wheal which comes and lasts for a long period of time. Now, this is a patient who's a 54-year-old female patient. Patient has a 2-year history of arterial skin eruptions lasting for up to a week at a time and resolving, leaving either a bruising or a brown pigmentation on the skin. Now, two things comes out from the picture. First, normal arterial wheals doesn't last more than 1 day, so that is something is unusual about that. And arterial wheals usually resolve without any trace of pigmentation. However, in this patient, there's like bruise like or brown like pigmentation was there inside a patient's skin. Patient also had additionally inflammatory polyarthritis. From his past investigation, we came to know that patient has some positive serologies, like patient's rheumatoid factors are weakly positive, and patient also has a strongly positive anti-nuclear antibody. If you see the patient has significant discrete and confluent arterial plaques, and then arterial plaques actually results in dusky pigmentations, and they measure from 2 to 4 centimeters, so that can be there in normal wheals, but this dusky pigmentation resolution, delayed resolution is not seen in normal arterial wheals. So what could have been our diagnosis? As you rightly think, it's a case of arterial vasculitis. That was our differential diagnosis also. So what you do, we did investigate a patient with a biopsy, and the biopsy reveals in histopathology superficial and deep perivascular interstitial polymerphenonuclear infiltrate with nuclear dust, leukocytoclasis, and also the RBC extravasation. So this is classical leukocytoclastic vasculitis presentation, like small vessel vasculitis presentation, which we found from the histopathology. And in direct immunofluorescence, IgM, IgA, and C3 was seen deposited around the blood vessels. So we did some additional investigation. Patient's complement levels came low, which is consistent with the hypocomplementemia. Further serologies reveals SSA antibody positivity, ribonuclear protein antibody positivity, and also anti-Smith antibody positivity. Her urine analysis was normal. So with all these reports, sorry, it's kind of getting stuck, we came to our final diagnosis that this patient has a hypocomplementic vasculitis, and we sent the patient to rheumatology, and finally the diagnosis was made of SLE. So this is something we need to know. All the patients of urticaria-like lesion may not be urticaria. We need to keep our differential diagnosis in place. There can be patients who bullous pemphigoid-like lesion which present like urticaria. There can be patient who, like lepromatous Hansen, which can present like urticaria, and of course arterial vasculitis, SLE. These are the differential diagnoses we need to keep in our mind. So how to differentiate between the classical urticaria and arterial vasculitis? As far as arterial vascular lesions are painful, In case of classical urticaria, it is more itchy. The lesions persist more than 24 hours. In case of arterial vasculitis, also they leave some dusky pigmentation after resolution of the lesions, which is not seen in case of urticaria. There can be angioedema present with classical urticaria. It can be present also in arterial vasculitis, but in case of arterial vasculitis, purpura can be present, which is not seen in classical urticaria lesions. Not much specific laboratory findings can be found in urticaria. However, hypocomplementia can be associated with arterial vasculitis. Of course, we need to do a skin biopsy. These are the very important indication for skin biopsy in patients of hives, which is persisting more than 24 hours. We can see a perivascular reaction in case of classic urticaria. In case of arterial vasculitis, we can find features of leukocytoclastic vasculitis. Also, we can find direct immune fluorescence positivity. So this is how we should be finding out if our patients is arterial vasculitis or urticaria. However, suspicion is the key. If the lesion stays more than 24 hours, if there is a residual pigmentation, always do a biopsy, and that is the message from these cases. Thank you.
Dr. Abhishek, for that wonderful presentation on different cases. So typically we have seen that urticaria mimickers are many, and one of the mimickers is a vasculitis, which we all know. And obviously the lesion lasting more than 24 hours is the key. So patient can always take the photograph and they can tell us. And obviously physical urticaria is one thing which we have not discussed, but well, physical urticaria is one patient can tell you that, well, this is my cause, this is how it looks. And many times patient understands the disease and it tries to avoid the triggers like heat, cold, pressure. Yeah, that is the thing about the urticaria. Yeah, there's one more case you discuss is about the failure of autoserum therapy and of omalizumab. Well, in India, we have a biosimilar of omalizumab is also available. For those who can't afford, you can always give them, because that is the most preferred therapy, because in COVID times, when the immunosuppression is a problem, omalizumab is not immunosuppressant. You can safely give it to the patients. You need not worry. Whereas in cyclosporine, if you go beyond in a COVID endemic area where there is a high patient load, you have to be aware that you can't give cyclosporine more than 1 to 2 mg per kg because of the immunosuppression. So that's why omalizumab is preferred. Obviously, the cost is a factor, but those who got really high IG as this patient, the omalizumab would have been a choice. In fact, omalizumab should have been a choice for almost all of our patients when your fourfold do not work. So that is the message we have. Well, we have still 3 to 5 minutes for the thing about the cases. Dr. Abhishek, just last 1 or 2 questions about your patients. There was one question which I didn't take is, have you found the difference between the original and biosimilar of omalizumab? Are there any differences? We have not done a study as such.
I have not done any study as such. I've only done, I've given 5 or 6 patients the new omalizumab. I had already given 68 patients of older omalizumab. That data is getting published now, as you are also part of that phase 4 study. Sir, I am a little circumspect about the new omalizumab. I'm not yet very convinced about the molecule. However, the price is very low. So that's very low compared to the original molecule. And the original molecule is mostly becoming unavailable also. It's very difficult now to get the original molecule. So I'm getting forced to use the omalizumab, this biosimilar omalizumab. I have given a couple of patients where the patient has not responded to 300 milligram omalizumab, this biosimilar. I have given 450 and then the patient responded. In case of original molecule, I hardly had to get to 450 milligram. That's the only observation I can say for the timing, but I must say the data is very small. Only 7 patients I have given till now. So I need to gather more experiences.
Right. Time will tell us how it is. Obviously, the original is preferred, but it is actually beyond reach of common man. So you can try a biosimilar, which is available. This was one question which was asked. Another question which one doctor has asked about the skin allergy blood test. Now, remember, none of the guidelines recommend that you do skin allergy test in all your patients. The Fadiatop assay or immunocap assay do not give you any clue. Just sensitization is possible, but if it is to be a cause, it has to be in substantial level, more than 20 IU per ml. That should be the reading of your immunocap assay, and which rarely happens. So don't go for those food allergy tests or skin prick tests routinely in your urticaria patients. They may have some role in allergic rhinitis and allergic asthma, but not in urticaria or atopic dermatitis. So don't go and waste 5 to 1,000 rupees on that. Instead of that, he can take a omalizumab injection to control, because this test will give you so many things positive, but that is not the cause. So that is one more thing which I thought I'd like to tell you. So just summarizing, we have a very interesting discussion. We are first a good presentation by Dr. Torsten Zuberbayer about the new management guidelines and the new algorithm, which will get published soon. Then we have got a healthy panel discussion on the tools and tricks of dermatology, and then the question answer from the patients, which are interesting. And then Dr. Abhishek presented interesting cases. All in all, it was a wholesome experience, a lot of learning from all of you. And I must thank Menarni for getting this happen, to get the international speaker and talk to us and know the best from the global team. With this, thank you very much. I hand it over to Menarni for the closing remarks. Thank you very much.
Oh, Dr. Kiran, thank you very much. I mean, it was a very engaging webinar and discussion among all the doctors. And I thank Dr. Janki, Dr. Abhishek Dey, Dr. Mukesh, who had to leave a little early, and also Dr. Torsten. In fact, all doctors were looking forward to hear to Dr. Torsten. And as you know, this was the second webinar on the subject, and we have one more planned on 22nd of August when we have Dr. Church, another international speaker who will be talking on the on the topic. So we have doctors who have joined from all parts of the country, and I thank everyone, because nowadays Sunday is a normal day. I mean, people like to go around. Still, we have so many people who have joined us for this webinar. That clearly shows that the thirst for knowledge and the update is very high among the doctors. One thing I also want to point out is that the original Blackstream, what we are selling in India, is same what is manufactured across the world. It's manufactured in Italy only. The same thing we are getting here, but not at a Mercedes price, but at an Indian price. So that is a good thing. Our price would be roughly 10-15% higher than the next price. I mean, it's not exorbitantly priced. It is priced within the reach of, I think it's 17 rupees or something per tablet, 16 or 17 rupees. So it is very well in the reach of the patient. It is not like omalizumab and other originators, because Menarini always thinks about the patient access should be important, because if the patient cannot afford, I mean, then any drug is of no use. So looking into this, we have made the product available across the country, and I'm sure many times doctors have told us that the literature is very good, but the results are not good, whatever they have tried. But I'm sure, because the literature the trials was done on the original, not on the local generics. So once you start using the original, you will get the same results. So with that closing remark, I will thank you once again, sir. And it was a pleasure, and I'm look forward for more engaging, meetings like this. And we are looking forward also for face-to-face meeting as soon as it happens. Thank you, sir. Thank you very much.
Thank you. Bye-bye.
Bye-bye.
Bye.
Bye-bye. Bye-bye.
Thank you very much.
Bye.
Thank you, sir. Thank you.